Welcome to the workshop, Graft-versus-Host Disease, Genitals. My name is Becky Dame, and I will be your moderator for this workshop. It is my pleasure to introduce today's speaker, Dr. Tosin Goje. Dr. Goje is an associate professor of obstetrics, gynecology, and reproductive biology at Cleveland Clinic's Lerner College of Medicine of Case Western Reserve University. She's the medical director of the Cleveland Clinics for Infant and Maternal Health and a staff member at Cleveland Clinic's Women's Health Institute Center for Specialized Women's Health. Dr. Goje specializes in treating patients with reproductive infectious diseases and non-infectious diseases of the vulva and vagina. So please join me today in welcoming Dr. Goje. Over to you.
Thank you so much. Thank you for that warm welcome. Good afternoon, good morning, good evening, wherever you are. And I'm hoping we have a great interactive session this afternoon. At the conclusion of this workshop, we should all understand who is at risk of developing genital GVHD after transplant, the signs and symptoms of genital GVHD in both men and women, and the treatment options for genital GVHD, including pharmacologic and non-pharmacologic therapy for men and women. So I am a storyteller because I believe we are not just medical record numbers or social security numbers. We're humans. And many times this is how patients show up in the clinic. A 46-year-old woman diagnosed with AML, she's married, a mother of 5 children, underwent a stem cell transplant with donor cells in 2008. Since transplant, she's suffered with GVHD in her eyes, intestines, the vulva, and the vagina. According to Ms. A, genital GVHD has caused dryness and pain that prevented her from having a normal sex life, as well as emotional problems and frustration. She was treated with steroid cream and cyclosporin cream that she inserted into the vagina every night. She was advised to use vaginal dilators in addition to the creams to treat scarring that may have occurred during the GVHD. After a year, her genital GVHD symptoms were significantly decreased and her sexual relationship was restored. I'm finally healthy inside and out. I'm a healthy and confident wife, mother, daughter, and friend, says Mrs. A. So this happy ending is what we hope each of our patients gets. And that's why this is a very, very important conversation that is dear to my heart. What are the potential sexual problems after transplant? First of all, I want to step back to say these potential problems should be discussed before transplant. And patients should be sent to or referred to the appropriate specialist before transplant. Decreased sexual desire, genital GVHD, hormonal dysfunction, especially in young women, erectile dysfunction in men, difficult or painful sexual intercourse, and infertility in couples that still desire childbirth. Sexual problems after transplant is important. There was an old study that showed that if you don't ask the patient might not discuss sexual problems after transplant. In the past, I've heard patients say, oh, I'm just grateful to be alive, so I never mentioned it to my doctors, and my doctors never asked me. And I think that culture must change. We must ask patients about problems encountered after transplant, because nobody talks about it. It's a painful discussion, met with discomfort. Patients have estrogen deficiency, testosterone deficiency. Young women have premature ovarian failure, which is defined as early menopause before the age of 40, and of course, chronic genital GVHD. What are the general risk factors for sexual problems after transplant, and what are the main culprits? So some patients have total body irradiation. Some have GVHD after transplant. Some patients is medication and drug interaction or a chronic medical problem that is compounded by transplant and, of course, psychological distress. And if we look at each of them, total body irradiation leads to gonadal failure. I had a patient who, at age 28, had premature ovarian failure and did not talk to anyone about it until she saw a survivor nurse who helped with some education. This led to decreased sexual desire, arousal, orgasm disorder, discomfort with intercourse, erectile dysfunction in men. And these are conditions that actually can be remediated. There are hormonal replacements for young women. Young women with premature ovarian failure, we can start them on either birth control pills or hormone replacement therapy, depending at what stage they come to the clinic. The same thing with erectile dysfunction in men. There are medications and also management of stress and biofeedback that can be employed. For GVHD, it leads to a lot of performance stress because there is a lot of scarring, which we'll talk about later. There's pain with intercourse that adds to performance stress. There's abnormal ejaculation in the male partner, and intercourse becomes impossible, and some women just give up. And there are possible interventions. We can use lubrication during intercourse. For my patients, I go stepwise. They can use water or silicone-based lubricator. If that does not work, we can compound vaginal vitamin E with hyaluronic acid. And most patients, you see the light on their face, like, hyaluronic acid, like what we use for our face? I say, yes, it can be compounded as a vaginal formulation. And of course, there's vaginal dilators. And in some patients, they can use a topical vaginal estrogen, a ring, a cream, a suppository, or vaginal DHEA for patients that cannot use estrogen. For medication, we can consider options of reducing the dose and even looking for alternative medications for them. If the risk factor is chronic medical problem, treatment of underlying medical problems is important. I have a young 40-something-year-old patient, a leukemia survivor, doing great, but she reacts adversely to some medications because she also has mental health disorders for which she takes medication. So we just had to have a roundtable discussion virtually with all her providers to see which medications are better suited for her, knowing that she has some underlying medical problems. And for psychological stress, patients will benefit from sex therapy, pelvic floor therapy, Reiki, yoga, biofeedback therapy, as they may be present in their locality. Genital chronic GVHD is quite prevalent, although we don't have the exact figures. 1/2 of patients transplanted with stem cells from a donor experience impaired sexual function after transplant. This develops primarily during the first year. Some studies will tell you from 7 months post-transplant up to like 3 years post-transplant. On an average, most people will develop genital GVHD in the later half of the first year post-transplant. So we have to have a good surveillance for patients as they follow up with us post-transplant. It's usually underreported. As I alluded to, people don't talk about these issues. Female prevalence, 24.9 to 69, and I think it's because we don't have good reporting. The median time is 7 to 10 months for females. In men, data is lacking, and one of the studies that has been cited many times in literature talks about a median time of 5.9 years. Early detection and treatment is important. In our practice, I prefer that patients have a gynecologic evaluation before transplant. And after transplant, they should have another evaluation and be followed up yearly. If they develop GVHD, they should be followed up 3 months after initiation of treatment, then 6 months, every 6 months, and then we can go every year, depending on how they are responding to treatment. Because early treatment of genital GVHD may halt its progress so that it does not get to severe genital GVHD. Men will usually return to pre-transplant functioning in 2 to 3 years. Women are less likely to return to pre-transplant sexual functioning. Women diagnosed with genital GVHD should have a lifelong follow-up and treatment. And as a gynecologist, as a vaginal specialist, I can tell you that women just get tired of the whole follow-up, and that's where advocacy comes in. That's where having teams like this, survivorship clinic, comes in to encourage these patients to continue with the treatment, because when they don't continue with treatment, there may be reversal of the gains. Psychological and psychosocial impact of GVHD is enormous. It takes a heavy psychological toll on women, from the inability to discuss it to having providers that have no understanding of what is going on. So it could lead to depression, anxiety, especially with intercourse, feeling of inadequacy with their partners, and body image issues, especially with patients who have severe GVHD. It impacts their relationship with their partners. My patients say kind words like, my partner is patient, my partner understands, but I would love to do more. I would love to be intimate. So it strains relationships. There's distorted body image, which leads to decreased sexual desire, and there's that perception that they are less desirable just because of the change in the anatomy of the female genitalia or male genitalia. There's reduction in the quality and quantity of sexual activity, and of course, impaired sexual function. Let's hone down to genital GVHD in women. Genital GVHD in women, or vulvar and vaginal GVHD, is the most common cause of symptoms post-transplant in the vulva and vagina, even in children. Untreated inflammation and fibrosis, which shows up as scarring in the vulva and vagina, may lead to total vaginal narrowing and closing of the vagina. As I said, I'm a storyteller, and my patients are the best. Sometimes when I see like advanced GVHD, I ask, tell me the story, what happened? And it's usually, I just was dealing with other things, and nobody said anything. So it's important we advocate and we ask our patients, because it significantly impacts the quality of life and interferes with sexual intimacy. Early detection and treatment of genital GVHD reduces pain by healing the eroded mucous membranes in the vagina, and I will show us some pictures. I just want to say at this point that my pictures might be a bit overwhelming for some of us because these are medical pictures, so bear with me. The prevalence of genital GVHD in women, as I said earlier, is underreported. So you have a wide range from 24% to 69%. And this could be underestimated or even underreported. If you appreciate tables, you'll see Spinelli and Zantomio and Chung and a few other researchers that have looked at genital GVHD. The numbers of patients they had was not a large population, except for Spinelli. But you can see the median age of these patients. They are young women, and this is the donor type. I mean, what this table tells us is addressing genital GVHD is really crucial, especially looking at the age of the patients. They are pretty young women at the prime of their lives. This pie chart here actually talks about the most common symptoms that women reported in a study of 27 women. And the majority, which was 10, was itching. And this is where misdiagnosis or underdiagnosis can come in. Because vaginal itching could be from allergy, it could be from contact dermatitis, it could be from yeast. So this patient presents with a symptom that has a lot of other differential diagnoses, and this could lead to a delay. So I always tell my residents, if the patient complains of itching and you've done over-the-counter miconazole and other anti-itch, you need to bring the patient in for examination. It might not be itch. It might not be yeast. I have a topic titled, Not Every Itch is Yeast. Vaginal itching, burning, and dryness are number one. Formation of white lines, scarring, adhesions, which is closure of the vagina, is also common. Loss of elasticity in the vagina. When patients say, why am I in pain? The vagina is supposed to be very elastic, enough to push out a 10-pound baby. And it becomes so rigid that any form of stretching actually makes it crack and bleed. So patients complain about post-intercourse bleeding or even just bleeding after exercise because there's loss of elasticity. Over time, there's narrowing of the vaginal canal. I had a lovely lady tell me, my partner said he can't get in. He can't get in. Did I leave a tampon or something in there? So I examined her and I said, there's nothing in there. It's just that the vagina over time has become almost like a tube, very narrow. And because it's lost elasticity, it's no longer pliable and soft and stretchy. So this leads to painful intercourse, pain with urinating because the vagina is related to the base of the bladder, abnormal discharge and swelling of the vagina. Patients often have more than one symptom. So it's important that they're evaluated to see what is going on. Now, I was talking about pictures and redness. So if you continue to go on this journey of genital GVHD with me, you will see this is for mild disease state. Following my arrow here, there is a small ulcer. This area is called the vestibule, which is the inner part of the vulva. There is a small ulcer forming. This will cause pain with penetration at intercourse. The urethra where we pee from is above, and when urine, which is acidic, touches this ulcer, it causes burning. So once again, I tell folks, a woman burning after urination or with urination that has negative urine cultures should be examined. Because these patients will call the doctor's office that I am burning, and a urine culture will be obtained or they will be treated for UTI, and they will keep calling. It's important we validate this symptom and examine. And this is extension. So if it's not treated, it just continues to extend. It's already starting on the other side. So this is mild genital chronic GVHD, diffuse redness and swelling of the vulva with some reticulation here, like a little lace. And if it persists, what happens is it progresses. So this lady had the little ulceration, and over time, she has narrowing of the vaginal opening. Now, if you continue on this journey with me, you will notice this V shape of the clitoral area. With progressive disease, what happens is it shuts down. It's called agglutination. So the clitoral area is stuck together, for lack of a better word. It's agglutinated, and slowly the opening of the vagina gets smaller. So this is vaginal narrowing and introital narrowing. This is another picture of a different patient. You can see this is where the clitoris was, but slowly it's being closed. So you will hear us use the word sclerosis, fibrosis. This is what is happening. If you look at her normal skin, this area is getting very white because it's getting sclerotic. This patient, on the other hand, has what we call fissures, moderate to severe fissures. Like someone took a small knife and just, cut the sides of the vulva. And all these things cause irritation in our patients. So what do? Providers must ask questions. And if those questions are not asked, I will recommend you speak up and say, I have the symptoms. Early recognition and treatment is important. So if the provider is not trained in female genitalia, a gynecologic consultation should be requested for this patient. Now, in order to have uniformity of how we diagnose GVHD, so that whether you're in Oklahoma or you're in United Kingdom, we're speaking the same language, the NIH came up with clinical scoring of genital chronic GVHD, where a score of 0 is assigned when patients are asymptomatic. A score of 1 is assigned when you have mild signs, which has no effect on coitus. There's just minimal discomfort. So that's the patient that just has the beginning of an ulcer. A score of 2 when patients are symptomatic and they have moderate signs like adhesions, causing pain with intercourse called dyspareunia, or even pain with gynecologic exam. And a score of 3 is assigned to patients that have advanced disease, like inability to put in a speculum. For some of these patients, I request like a pediatric or a newborn speculum. And even with that, you can't do a thorough exam. For one of my lovely patients, I could not see the cervix. I could not see the cervix because the whole area was stenotic. It was closed. Treatment does not change graft-versus-host disease. What it does is it halts the progression. It's not common to have reversal without surgery. And even when we have reversal from surgery, if it's not actively managed medically, it's going to actually go back to status quo. So when we talk about treatment, we want to start by correcting estrogen deficiency, because that is what starts most of the symptoms we have. We correct estrogen deficiency by using vaginal estrogen, and we also add highly potent topical steroids. Clobetasol propionate ointment, 0.05%, is what is commonly used in the United States. For patients who cannot tolerate clobetasol or have failed clobetasol, tacrolimus ointment or cyclosporine ointment can be used in addition to clobetasol or alone. That is for the vulva. For the vagina, this is a bit more complicated because most patients that have vaginal symptoms also have vulvar symptoms. So intravaginal estrogen, whether as a suppository or as a cream, intravaginal steroids. Many times the intravaginal steroid has to be compounded. Tacrolimus cream or suppository can be used also. Patients should be encouraged to dilate. They can go to any of the stores, or some of the cancer centers have gradiated dilators for women. Dilation is important to avoid vaginal narrowing and vaginal stricture and vaginal stenosis. If patients are in a relationship, we encourage them to have intercourse at least twice a week, because either intercourse or dilation helps to break the filmy adhesion before they become fibrotic, and then patients need a surgical intervention. So patients with vaginal stenosis, synechia, fibrosis, in addition to everything we've talked about, may be candidates for surgical intervention for lysis or reconstruction. At every point, patients should be surveilled. So young women younger than the age of 40, their blood tests for follicle-stimulating hormone, FSH, should be checked. And if a diagnosis of premature ovarian failure is made, they should be started on hormone replacement. Patients that are not sexually active should be encouraged to dilate, even if they don't have stricture. Avoidance of irritating over-the-counter feminine products is important, because many times the vagina, even when there's no symptom, is fragile, and use of irritating over-the-counter vaginal products actually aggravates the vagina. I always recommend simple emollients, whether it's olive oil, coconut oil, aquaphor, something that is simple and hypoallergenic. Now, because itching is the most commonly reported symptom, patients with itching should be tested for infection. The fact that a patient has genital GVHD does not exclude or rule out yeast infection or bacterial vaginosis that could also cause itching. Patients with genital GVHD have a higher risk of reactivation of human papilloma virus, and secondary malignancy screening should be done. They should have pap smears yearly at post-transplant, and then it can be spaced out over the years depending on how stable they are. What are my recommendations for monitoring? We said it earlier. Genital exams at 3 to 6 months after transplant, or sooner if the patient is symptomatic, and then we can move to annually. Always consider gynecologic exam at a minimum of 3 months with patients that have active GVHD. Things can change quickly. Cervical cytology, pap smear with HPV annually, and if the patient is young and meets the age criteria of 45, consider HPV vaccine along with the oncologist. And anytime a patient who is stable on your regimen has a flare, please bring them back and consider infection or an allergic or irritant contact dermatitis that can also present like GVHD. Should you avoid penetrative sex while you have genital GVHD? The answer is no. You can have penetrative sex if you're comfortable. Patients will also ask, can I have sex when I'm using the topical estrogen or the vaginal DHEA? The answer is yes. These are very low dose products that should not affect your partner. And some patients will also use 2 to 5% topical lidocaine at the opening of the vagina prior to intercourse, just to prevent pain. Most patients will use the topical lidocaine pea size 15 to 20 minutes before intercourse to help with penetration. Vaginal dilatation or intercourse twice a week, as we said, is recommended to prevent adhesion and vaginal stenosis. And a vaginal exam can also help. And that's why when patients have active GVHD, we recommend they have follow-ups at least every 3 months until the initial treatment has given us some relief of the symptoms. Topical medications for women with genital GVHD is pretty available in the United States. For patients that have vaginal involvement, we tend to use steroids first, unless there's a contraindication to steroids. Hydrocortisone acetate is a rectal suppository. We actually use it as a vaginal suppository in patients. The reason is it's already pre-formulated, and most of the time it's paid for by insurance and available all over the country. Hydrocortisone as a 10% foam or gel has to be compounded, and not every community has a compounding pharmacy, and we don't want to delay treatment. If the patient cannot tolerate steroid, we can use intravaginal clindamycin, 2%, or we could use the tacrolimus, as I mentioned earlier, as a vaginal suppository. For the topical, clobetasol is what we use for vulvar involvement, twice daily for 6 weeks, then daily for 6 weeks, and then we taper down to 3 times weekly. Patients will always ask about steroid and thinning of the skin. There is no evidence that using a small amount of topical steroid like a pea size 2 times a week for a year is going to cause thinning. There are studies from New Zealand and Australia in patients with other vulvar dermatosis, and even children have tolerated it. The concern is when people are using a lot of it for a prolonged period of time. And a patient who needs steroids every day for a year should actually be re-examined. Most likely the medication is not effective. Vaginal DHEA can be compounded, or it can be obtained as a generic formulation from a pharmacy, and is used the same way. The compounded has a higher dose of the DHEA. The formulary is called Intra Rosa and has a lesser strength. But it's not every community that has a compounding pharmacy. At the same time, it's not every insurance that wants to pay for the formulary. So it depends on what is available. This is a table just to show different regimens for patients. You can see here estrogen was twice a week, and they continued as twice a week up to week 23. Tacrolimus was every other day. Clobetasol was every other day. Then they tapered it to twice a week, then once a week, and the same thing with vaginal dilators. So it's not set in stone, but it's important that patients use this medication for a longer period of time and not just for a week or two. Maintain patency of the vagina by preventing adhesions and vaginal stenosis. In non-sexually active patients, as we said, dilators should be encouraged. It helps with scarring and narrowing. Recently, I had a patient come in for follow-up. In 2020, she had surgery and she was doing well. However, she stopped using the steroid and the vaginal estrogen after surgery. And the surgery was in 2020. And according to my patient, I was doing well after surgery and I slipped off. I stopped using the vaginal estrogen and clobetasol. And we're back to where we started. She's back with vaginal narrowing and adhesions. And she's not interested in surgery again. So we're going to try self-dilation, starting from the smallest size, coating the dilator with some clobetasol and estrogen, and trying to do it every night, and then taper down to twice a week after 6 weeks. For patients that have moderate to severe GVHD, instead of using a vaginal suppository, a vaginal ring might be better because the vaginal ring also helps to keep the vaginal canal patent and is inserted and switched out every 3 months. In addition to the vaginal ring, they should also continue to coat their dilators with either topical estrogen or DHEA every time they dilate. Pelvic floor therapy, I think, is very important. It helps our patients to get empowered. Sometimes patients have heard negative things about pelvic floor therapy, and they don't want to consult a therapist. But I always encourage them. Pelvic floor therapy is important. Biofeedback is important. It helps to empower patients back. Consulting a sex therapist or a family health therapist is also important. Behavioral health therapists, mental health therapists, any help that we can give to support our patients, we should always advocate for it. To improve sexual health, in addition to reaching out to a therapist, you should talk to your gynecologist. Sometimes patients are prescribed vaginal estrogen, and because of the bad rap it has in the media, they don't use it. Talk to your gynecologist about your hormone therapy because it helps to improve lubrication. And if you don't want to use hormone therapy, talk about hyaluronic acid or vitamin E that can be compounded for you. And also talk to your partner about your difficulties. This is a couple's problem, and the couple should go together. Keep intimacy alive. I have patients who say we don't have penetrative sex, but Dr. Goje, we are happy. We have other sexual encounters. We have other things we do. We just don't have penile vaginal penetrative sex. But that keeps intimacy going and alive. So briefly, in the next 5 to 10 minutes, I'll talk about genital GVHD in men. Very little is documented. The biggest study for men actually was from Simon Mueller. And the symptoms are a decreased desire to have sex, redness or rash on the penis, ulcers on the penis, inflammation, inability to ejaculate, and narrowing of the urethra. And these are pictures from Mueller et al. You can see the sclerosis, which is the whiteness. There's change in skin color of the head of the penis. There's some redness with white line. And of course, there's difficulty or pain with retracting the foreskin in uncircumcised men because of scarring and adhesions. Treatment is the same, once or twice daily high-potency steroid ointment. If they cannot tolerate topical clobetasol and they have genital lichen sclerosis-like presentation, they may benefit from tacrolimus, which is a topical calcineurin inhibitor. Circumcision in case of tight foreskin is also advocated. Testosterone replacement therapy for patients with low testosterone is also advocated for. We must discuss with our providers. And if you can discuss with provider, you can actually send a message to your survivorship team to ask questions. Early recognition of genital GVHD in men is important, and urologic consultation should be requested by all patients, even when there's no symptoms. We should not wait for symptoms before we request urologic consultation for our patients. So what are my key points today? Check frequently for symptoms of genital GVHD. If you have symptoms that may be genital GVHD, request a gynecologic or urologic referral. Wash with warm water and soap. Avoid over-the-counter allergens because they can irritate a fragile skin. Avoid perfumed products. Wear loose cotton or cotton-lined undergarments. Change after swimming and athletic activities. And please always request supportive therapy. Thank you very much.
Thank you, Dr. Goje, for this excellent presentation, and again, not discussed like we should discuss it. We will now begin the question and answer session. If you have a question for Dr. Goje, please use the chat box on the left side of the screen to submit your question. We will answer as many questions as possible. And our first question today is how to know if vaginal itching and burning is vaginal GVHD or skin GVHD?
Excellent question. The first thing I ask patients is, you're itching, especially women, it's just a sensation. Try to tease it out. Is it the groin? Is it the labia or the vulva, or is it inside the vagina? That's the first. And many times with patients, they're able to tease it out. Take a mirror or ask your partner to take pictures and look at where the skin changes are. If you don't see any skin changes on the labia, you pat the lips, as we call it, nothing, then most likely it's in the vagina. And as a patient, you can't really see inside the vagina. You need a provider to look at it.
Thank you. And to your knowledge, are there specialists for vaginal GVHD?
So they are not specialists trained just in vaginal GVHD, but they are specialists who are trained in vaginal disorders. That is where I come from. There are providers who have gotten extra training from maybe ISSVD, the International Society for Vulvovaginal Disorders, or from other societies, and are interested in this work. And I think some of the websites also have like names of providers who are interested in taking care of patients.
Thank you. One of our questions is, what hormone replacement should I use? This patient is currently using a vaginal cream insert, Replens for atrophy and dryness, and occasionally but not regularly. And they are also on an oral over-the-counter estrogen.
Depending on her age and her symptoms, I know based on evidence that if she became postmenopausal from her procedures before age 40, she should be on hormone replacement therapy, meaning estrogen and progesterone, because it also has other benefits in our general well-being. That is one. Two, if she's not a candidate for that, then she uses vaginal estrogen. Replens is a moisturizer, but if we have dryness from GVHD with that stricture and, tightening, that is not enough. She will need some vaginal estrogen or a vaginal DHEA. She just needs to consult with her oncologist to decide which is best for her.
Thank you. I think you've answered this, but we'll ask it again. Does GVHD of the vagina ever clear up, or is it an indefinite problem?
It improves. I've seen patients get better almost like 80-90%. I've seen patients that were so stenotic that I could not see their cervix, and by the end of 1 year, they had opened enough for us to see the cervix. It just takes diligence. It improves. I have not seen anyone go back to pre-transplant, like when they were in their 30s, but pain goes away, lubrication gets better, and even some are able to have intercourse with their partners.
Right, thank you. And did you mention estrogen cream on the dilators themselves? If so, how often should they do this, and what they should be using with a lubricant? Excellent.
So I recommend to use vaginal estrogen twice a week. The evidence for vaginal estrogen was to use 1 gram, and most of the tubes come with a gradiated applicator, 1 gram daily for 2 weeks, and then twice a week. So for dilation, for the day you're using your dilator, instead of just inserting the estrogen, use it on the dilator. So let's say a 7-day regimen. Every night, get some aquaphor, some coconut oil, or some olive oil to coat your dilator and dilate. But for the 2 nights that you use your estrogen, use the estrogen on the dilator. The same thing if you're using a compounded hydrocortisone cream in the vagina, like twice a week. The days you use it, don't insert, use it on the dilator because it's going to stick and coat the vagina better than when you just put it in.
Right. We have you had mentioned the pelvic physical therapy, and they're asking when that should be added to the treatment regimen.
The moment you start to have pain and you have at least used your vaginal creams or dilator for a month to empower you, you should start pelvic therapy. And I will explain why. Most women shy away from pelvic therapy because it's invasive of their privacy and they think it's going to result to more pain. So I tell my patients, if you can dilate yourself and you're not hurting, you're not bleeding, then you're ready for pelvic floor. And if you've started your creams to help with lubrication, you're ready for pelvic floor. But I don't start pelvic floor first and then say dilate after a month. It's those steps first, then pelvic floor, maybe within a month or 2, depending on how comfortable the patient is.
Do you have a protocol on how to follow women after transplant for early diagnosis of graft-versus-host disease and then treatment guidelines after diagnosis?
My protocol is not from any research. It's from my patients. After transplant, they should have a well woman exam because there's increased risk of HPV and premature ovarian failure. They should have that well woman exam, thorough, covering everything from testings to questions. And then if they have no symptoms, they should be seen in 6 months. I see patients every 6 months for a year or 2. And if they are doing well, then I see them every year. But for patients who are symptomatic and I start on medication, I want to see them 3 months after starting the medication. I want to make sure that it's working. The regimen we've put together of twice a week hydrocortisone, twice a week estrogen is working. And after 3 months visit, if they're better, I move them to the 6 months for a year or 2. And if they keep doing better, then I see them once a year. But it's a lifelong follow-up once a year.
Perfect. Do you have a recommendation for women who can't use estrogen-based products because of a history of breast cancer? This particular question is related to that they're not having dryness, but just soreness.
Yes. So a patient like that with soreness, first of all, I ask, is this soreness or burning or pain? If it's just burning or pain, they can use vaginal gabapentin. Vaginal gabapentin can be compounded as a 4% or 6% as an insert in the vagina. Gabapentin is a medication used for pain. I love the vaginal route because it's with less side effect if it's pain. If it's soreness, pelvic floor therapy will help with muscle relaxation. Sometimes there are other medications that can be compounded as a muscle relaxant for the vagina, like baclofen. These are all non-hormonal. But to keep the area lubricated, which is important, they can use the Replens. They can use other over-the-counter, or they can compound hyaluronic acid, just like we use it for the face, or vitamin E as a vaginal cream. And all these are non-hormonal.
Wonderful. So there's a question. How can you distinguish between lichen sclerosis, lichen planus, and GVHD of the vulva?
Excellent question. It's not a straightforward answer, and many times patients have been referred to me for genital GVHD, and after examination and looking at the grading, it's not genital GVHD, it's atrophic vaginitis from lack of hormones, which could be also a side effect of transplant. Lichen sclerosis has clear stigmata, and I'll name three. One, over time, lichen sclerosis has agglutination of the clitoral hood. Lichen sclerosis, you lose the labia minora. Lichen sclerosis actually has what we call a figure of 8 pattern, whereby the hypopigmentation or lightening of the skin covers the entire clitoral area, and the vagina narrows down and covers the anal opening. So it's like a figure of 8 appearance. It goes all the way to surround the anal opening. And then there's what we call the cellophane paper or crinkled skin appearance, whereby the skin is thin and looks like someone squeezed a newspaper and changed their mind and tried to flatten it out. So there are clear stigmata of lichen sclerosis. Yes, it has itching associated with it. It could be in a lady who is having atrophic vaginitis. Lichen planus, on the other hand, is a bit different too. Lichen planus tends to have multiple sites. Lichen sclerosis tends to be in the vulva only, rarely vagina. Lichen planus could be in the vagina, it could be in the mouth, and it could be in the vulva. I've seen patients whose first diagnosis of lichen planus was by the dentist. Now, lichen planus does not cause fibrosis or sclerosis. It causes more of denudation, like someone took a knife and scraped off a layer of the skin. The area is red. It looks like ulcer, very fragile to touch. They can bleed just from contact. So that is, and if lichen planus extends into the vagina, these are patients that have copious yellow-green mucoid kind of discharge, just because of that inflammation that is also happening in the vagina. And of course, with GVHD, you grade it. Rarely do you have GVHD being as aggressive as you see the copious discharge in lichen planus. However, they're all treated to a large extent the same way. Estrogen or DHEA, steroids, or tacrolimus. Thank you.
Thank you. So our another question we have coming up here is what are the, if any, medical procedures that can be done for extreme tightness of the vagina other than dilators, hormone inserts, and the extra lubrication? Because for this patient, those didn't work.
Surgery. We have surgeons, urologic surgeons, and gynecology surgeons, and pelvic floor surgeons who are dedicated to doing this. Not just for GVHD, but for other conditions, like patients that had vaginal radiation for cervical cancer. They also present with stricture. So this patient can have surgery.
Perfect. And what can be done to correct vaginal atrophy?
The best treatment for vaginal atrophy is to use hormones, whether it's vaginal estrogen or DHEA. DHEA, I have seen in my breast cancer patients, is accepted by their oncologist. I think is dihydroepiandrosterone. Because every time I start a vaginal hormone, I always reach out to the oncologist. For my breast cancer patients, many of them have been candidates for DHEA if they are not candidates for vaginal estrogen. So that is what I'll recommend for atrophy. Osphena, which is an oral medication, is also a good medication for moderate to severe vaginal atrophy. It's an oral medication. It's a SERM. And those are the three things, really, that will be effective. Everything else will just be a lubricant or a palliative.
Okay. So a question we have coming in is complete loss of libido a side effect of the chemotherapy and radiation treatments involved with the transplant?
No, it's a side effect of many things. That's why we said it could come from body irradiation. It could come from chronic medical conditions like diabetes or hypertension in addition to the transplant that the patient had. It could be from medications that patients have to take for cancer or for other things. So it's not just transplant that causes loss of libido. There are other risk factors involved. It might just be accentuated in the patient who had bone marrow transplant in addition to uncontrolled diabetes, for example.
Okay. So this is a very sensitive question, I think. Do you recommend, when do you recommend to start monitoring pediatric and adolescent patients, and how often?
This is a sensitive question because I take care of children and it's very emotional. I don't really want pediatric children to have examinations. I think sending them to a pediatric gynecologist or a pediatrician who is interested in that age group and that condition, questions should be asked first. So the best way to monitor the children is to know what the baseline questions are and to ask questions and only examine them when it's absolutely necessary.
Thank you. Thank you. Wonderful. Well, on behalf of the BMT InfoNet and our partners, I'd like to thank you, Dr. Goje, for this very helpful presentation. And thank you to the audience for your excellent questions. Please contact BMT InfoNet if we can help you in any way.